Well, John, I'd like to thank you for once inviting me to debate a subject where I feel I am correct rather than incorrect in debating it. And I'd like to congratulate Dr. Smith on defending the indefensible. What I'd like to do is show you some of the same data, but with a somewhat different interpretation. So these are my disclosures. I certainly would welcome anybody from industry to say that I'd like to add a few more. And so I'm going to debate the topic, should we do surveillance imaging for large cell lymphoma patients in remission? An absolute, unequivocal no. Now, he mentioned some of this, and there's a Choosing Wisely program that's been put on by many of the organizations, particularly ASH, in response to the internal medicine query. And what they said in one of their Choosing Wisely edicts is that you should limit the use of surveillance in asymptomatic patients in complete remission from aggressive large cell lymphoma or non-Hodgkin's lymphoma. In fact, 5 organizations recommend this advice, including the American Society of Hematology, the American Society of Clinical Oncology, the European Society of Medical Oncology, the American Board of Internal Medicine, and the National Cancer Center Network. So what do they know that we should know? First thing, that recurrence is occurring in diffuse large B-cell lymphoma with negative PET scans following complete remission is fairly uncommon. There's about 20% using modern criteria. So mind you, 20% of patients are destined to relapse, okay, with a negative PET scan. Indeed, in the most experienced hands, a negative predictive value approaches 90%. And in fact, as Dr. Smith pointed out, most relapses occur within the first 2 years. But in only 20% of those complete remissions, and Dr. Smith has admitted that, is the relapse first detected by imaging as opposed to symptoms or signs related to or found by the physician. The patient comes in and says, I've got something wrong. I'm running some fever, I don't feel well, whatever have you. In fact, only 20% of the relapses, and I think Dr. Smith agrees with that, from complete remission occurs in that 20% of patients who relapse from complete remission. So you don't have to be an Einstein. I'm not a great statistician. In fact, I don't know statistics at all. But I know that if you're going to pick it up 20% of the time just on routine surveillance, and you have a 20% relapse rate, that leaves you with 4% of patients. And point of fact is, Dr. Smith pointed out that the number is actually lower. It's less than 2%. 20% of 20% is 4%. Now, in those patients detected early by PET, there are not a bit of data indicating, although he shows you a few numbers, that early detection, and there's 4% of patients, mind you, this is just less than 4%, 2% of patients who are in CR, that this confers a better prognosis by getting it early. He can show you a few numbers. For instance, a Scandinavian study comparing Sweden, which did serial imaging, everything else was the same by the board, with Denmark, who didn't do surveilling imaging, found no difference in survival. This isn't 20 patients from Memorial or 40 patients from Memorial. This is 1,200 patients. Now, you don't need to be a statistician to look at those curves and say there isn't a whit of difference between doing serial studies and non-serial studies in terms of overall survival. Now, what is true is that those patients who have an I or higher IPI, the lower two curves, do more poorly than those who have a good IPI. But nevertheless, there is not a whit of data to show that survival in these 1,200 patients was improved by the use of surveillance studies, scans, whether they're CAT scans or PET scans. Now, it is true, and they prove this, that the IPI that's high does more poorly than those who are low. And look at the relapse rate here. This is really relapse or death. If you'll see roughly, the relapse rate is about 20%, and those high IPIs, much less than those with the lower IPIs. And nevertheless, as I showed you before, there isn't one bit of data to show that there's any improvement in survival. Now, what's the downside of doing serial scans? As Dr. Smith pointed out, people, when they come in for getting a CAT scan, they're all very, very frightened. And point of fact is they run 10 to 20 millimeters greater blood pressure than when they come in to see me after the CAT scan is done or the PET scan is done. 2, you're applying unnecessary radiation. 3, there's an increased financial cost to the patient and the healthcare system. Dr. Smith says, Cost doesn't bother me at all. You know, money is no object as long as it's not your money. And lastly, false positive may provoke unnecessary studies with increased mortality and increased morbidity. So when is imaging invariably ordered when following the patient? Usually you do this imaging when the patient comes and tells you that I have something that's wrong, or you pick up something that's wrong, either abnormal laboratory studies, LDH, B symptoms, a mass, or pain prompting the use of imaging. Most of the time when we pick it up on imaging is after the patient or you have some reason to think so. So I did a mini meta-analysis and a review of 21 articles, some of which were quoted by Dr. Smith, found that 19 concluded there was no value in serial imaging studies for aggressive lymphoma. In 2 small retrospective studies, one of which was quoted by Dr. Smith, there was some limited value thought to be gained by serial studies in special circumstances. And those special circumstances are those patients with a very high IPI who have very high-grade disease with a greater tendency to relapse. And most of those patients will relapse within a year. The problem is even when you do serial studies there, these patients relapse so quickly that it doesn't really make any difference. They'll come into you in a very, very early stage of their relapse. So what I'm trying to say is even in those with a high IPI, there's not a whit of data to really show that picking it up with surveillance PET scans or CAT scans is going to make one iota of difference. The one place where I think you should do it is where you have a borderline negative study. That's somebody with perhaps a Deauville-4 score on the SUV uptake. But for the most part, there is absolutely no reason to do routine surveillance on patients who are in complete remission. So in conclusion, there are a maximum of 20% relapses in large cell lymphoma patients in complete remission by PET or CAT, and the 20% range is mostly in those high-risk patients. It is rare for serial imaging initially to detect relapse. Signs and symptoms often provoke the detecting imaging. Initial PET pickups are less than 4%. There are no data that early detection enhances survival. Serial studies are expensive, entails radiation, and are anxiety-provoking. False positives may require unnecessary procedures with increased morbidity and mortality in some rare instances. Few relapses occur after 2 years, so no scanning is absolutely not indicated for any patient. And 1 year is usually enough to determine that high-risk patients will not relapse, because if they're going to relapse, they're going to relapse very early. There are only limited instances where serial studies are needed. Now you know what they know. And I'd like to thank you for your attention and invite you to Lymphoma Myeloma 2016, where Dr. Leonard will also chair the lymphoma sections at the historic Noble Waldorf Astoria Hotel in New York City on October 13th to 15th, 2016. And again, thank you for your attention.